My name's Linda Jillison. I'm here as usual to welcome you to our 19th annual, hardly seems possible, community lecture series sponsored by the Alumni Association, as you all know. I'll do my usual thing about asking people to turn off their cell phones, reminding you that we are being taped by MCAT, and by the end of the series, just 2 weeks from now, we should be able to let you know the schedule for broadcast of these lectures. So you may want to catch them if you've missed one live and in person. I think that's all I have to say, except to introduce our lecturer for tonight. We have a somewhat more sparse audience, and a couple of people were commenting on the way in that there's some really amazing competition for this lecture. Really big league competition. And you can believe me about that. But we are here to listen to a lecture by Brian Cochran, and I think it's going to be a very informative and fun lecture. Brian's one of the few people in this year's lecture series with whom I was already acquainted. He's been here since 2003, and he's worked, I know him as one of those good citizens on the campus who's done a good bit of service and been on committees and served as the co-director of the Women and Gender Studies program for I'm not sure how many years, but that's a task which not everybody takes on, and it's good to have people like Brian who are willing to do it. Brian's here to talk about something which is of particular interest to him and about which we hear a lot in our day and time. And right now, specifically, Brian's going to talk to us about understanding the LGBT mental health disparities. So with no further ado, let me just introduce to you Professor Brian Cochran.
Thank you so much for that thoughtful introduction. Is everyone able to hear me all right in the back and everywhere? Excellent. This is a wonderful opportunity for me to get to talk about something that is really near and dear to my heart and an area of research that I've been working on since I was a graduate student in 1997. So I'm a psychologist by training. I'm a clinical psychologist. I think I'm the third psychologist in a row that you all have had as part of this lecture series. A series of shrink wraps, I guess as we'll call them. And as a burgeoning psychologist, this was my area of interest in terms of trying to understand the health disparities that LGBT individuals face and work ultimately to trying to eliminate those disparities. So I'm going to give you a pretty broad overview of disparity research with regard to LGBT populations. I'm going to start a little bit by talking about terminology and clarifying what it is that I'm going to be discussing. And then I'm going to talk about what might explain, in other words, help you to understand why those disparities exist before moving into how we can start to address those disparities and work towards health equity. This particular picture I took this summer after, as many of you I'm sure remember, the Pulse massacre in Orlando. Our university, under Roy Singstrom's leadership, mounted a really thoughtful response to that. And this was at a vigil that we held outside of Main Hall. So I thought it was appropriate to begin this talk with a photograph of that momentous and really important way of paying tribute to the victims of that event. So terminology, I want to discuss the terms that I'll be using. I'll use a lot of terms interchangeably. It's really interesting to think if I had given this talk 15 years ago, probably I'd have to explain LGBT to 90% of the audience. It's very different. This has become part of our national lexicon in terms of increasing interest in LGBT rights, understanding LGBT disparities and other issues that people face. There's problems with this acronym. There's so many problems with this acronym. The first one is, obviously it stands for lesbian, gay, bisexual, and transgender. It lumps together the concept of sexual orientation, lesbian, gay, and bisexual individuals, and gender identity, which would include transgender individuals, but many other people who fit underneath that transgender umbrella. The term transgender really is a way of describing people who have a different gender identity than what their assigned sex was at birth. People who also may fall underneath the transgender umbrella might include people who describe themselves as non-binary, meaning They don't fit into the rigid classification of male and female that determines a lot of the different things in our society, the color that we decorate our babies' nurseries with, the types of restrooms that we go into, and so forth. People who are non-binary deliberately do not fit into that categorization. People also use the term gender queer as a way of addressing the fact that many people not only do not subscribe to the gender binarity, but deliberately do not fit into that as well. So one of the issues with this acronym is it could be much longer. It could be LGBTQI, queer questioning, intersex, non-binary, and so forth. Not all subpopulations within this acronym are equally studied. So most of the research in this area has been on the basis of people of minority sexual orientation and not so much people who are transgender or have a minority gender identity. So a number of different issues with this acronym. What percentage of the population are we talking about? A lot of people are curious about that. The LGB part, in terms of minority sexual orientation, Gary Gates from the Williams Institute at UCLA has done a number of studies trying to estimate demography of the LGB and LGBT population, and estimates that basically about 3.5% of people in the United States might identify as lesbian, gay, or bisexual. Probably somewhere between 0.3 and 0.7% of people would identify as transgender or under that umbrella, depending on how that's defined. So roughly we're talking about 4 to 5% of the population, depending on how you look at it. Other terminological issues. So I'm a clinical psychologist. I think a lot about mental health. I'm going to be using terminology related to mental health that's pretty broad and general in this discussion, talking about psychological distress, also talking a little bit about different disorders that are classified in our diagnostic manual, the DSM, which you've probably heard of, the Diagnostic and Statistical Manual of Mental Disorders. So as we look at different rates, for example, of PTSD, post-traumatic stress disorder, depression, and so forth, I'll be referencing the DSM in terms of how those classifications are made. And finally, health disparities, a term that is also getting increased traction. The U.S. Department of Health and Human Services defines health disparities as adverse outcomes for communities that have, as a result of social, economic, or environmental disadvantage, systematically experienced greater obstacles to health. So health disparities are ways of identifying groups that may experience elevated rates of certain conditions, whether they be mental health, physical health conditions, or somewhere in between. It's also important to note that health equity is a new kind of buzzword in this field, and this is the idea of eliminating health disparities and moving towards a place where we no longer have those sorts of social, economic, or environmental disadvantages that put one group in a different place regarding to another. So health disparities versus health equity is part of the terminology I'll be using too. So the history of LGBT mental health research is a fairly brief one. When I started my career as a graduate student, there were no people studying LGBT health research and psychology. I was looking for a mentor to try to help train me in terms of being able to do this sort of research, and really none existed. That changed really in the 1990s in terms of increasing interest related to HIV and AIDS, where people were starting to study communities such as men who have sex with men to try to figure out what are the health risks associated with these different populations. A lot of increased funding was available for people to do HIV-related research, and a lot of psychologists and other researchers started to do LGBT health research under the auspices of this funding. So while they were also studying issues related to HIV risk, they started to study things like sexual orientation identity development, mental health of sexual minorities, and so forth, and this became a burgeoning field. And in the 1990s, a lot of research started really to focus on the mental health needs of these different populations. And that's kind of where I came into the field. So as a graduate student, I started to do a little bit of research looking at homeless adolescents. I was working in a lab where we were studying homeless youth in Seattle. I did my graduate work at University of Washington. And we started to notice that a disproportionate number of our youth seemed to identify as lesbian, gay, bisexual, or transgender. About a third of them did. And in some homelessness studies, about 40% of youth identify as LGBT. So you might think about, why does that health disparity exist? Well, for many of the youth in our study, it was based on parental rejection, being kicked out of the home when they came out, having an unsafe place to go back to, facing rejection from not only their families, but from the broader community as well. So this started to really pique my interest in terms of figuring out, how can we help set these people on a different trajectory so that they're not experiencing lifelong disparities. I then started to do a little bit of research in LGBT-specific substance use treatment, which I'll allude to some later. It's another interest of mine, trying to figure out how to make appropriate treatment resources for people who identify as sexual or gender minorities. So earliest phases of research in this area were identifying the health disparities. The second phase, I believe, is really trying to do the understanding part. What are the explanatory mechanisms that put someone at risk on the basis of sexual orientation or gender identity for a number of different mental health conditions? And then I think the current and future directions, as I alluded to before, how do we really work to eliminate these disparities? What are the things that we can do as mental health providers? Of course, that's my particular interest. But what are the things that we can do as citizens of a broader society to work to eliminate these LGBT health disparities? I'm going to briefly go through disparity findings. There's a number of different studies that have really emerged in the past couple of decades to try to illuminate these. I just picked a few recent and representative ones, so this is by no means the whole body of research with regard to LGBT health disparities. But one of the large studies that has really started to illuminate these disparities is the National Health Interview Survey. This is a survey given to a lot of different people. It's a so-called population-based sampling method, meaning everyone in the population has an equal chance of being selected for this study. Maybe you've been selected for one of these studies as well. Almost 70,000 people were recruited. One of the things that this particular study does is it does ask people about sexual orientation and gender identity. A lot of surveys do not. For example, our census, conducted every 10 years, does not ask about sexual orientation or gender identity beyond the binary of male and female. So we really don't have good population estimates of how many people identify as LGBT in the United States, but I digress. Anyway, so from this particular survey, there's a number of different health disparities that were identified. This first slide is about women, lesbian women versus heterosexual women, endorsing so-called moderate psychological distress, depression, anxiety, and other symptomatology. The odds ratio there is 1.34, and I know not everybody knows what that means. Odds ratio is, by virtue of being a member in a certain group, how much more or less likely are you to have a particular condition? So 1 is equally likely, higher than 1 is more likely, lower than 1 is less likely. So in this case, if you are a lesbian identified woman, you are 1.34 times more likely to experience moderate psychological distress in comparison with a woman who identifies as heterosexual. The odds ratios for heavy drinking, much higher, 2.63, heavy smoking, 2.29. And then if we look at bisexual women versus heterosexual women, and this is commensurate with a number of different research studies indicating that identifying as bisexual actually may place people at even greater risks than identifying as lesbian or gay. The thought behind that is that perhaps people who are bisexual find that they don't necessarily have a home in the heterosexual community, and they may be somewhat ostracized by lesbian and gay individuals as well, who may label their identity as a phase or think that it's different from a lesbian or gay identity and may not be as supportive. So bisexual women, much more likely, 3.69 times more likely to endorse severe psychological distress. Similar findings for heavy drinking and moderate smoking. If we look at gay men versus heterosexual men, the odds ratio of severe psychological distress, almost 3 times more likely to be endorsed by gay men in comparison to heterosexual men. The odds ratios for heavy drinking and moderate smoking are about of a magnitude of 2, so about twice as likely. And then similar findings here if we look at bisexual men versus heterosexual men, the increased likelihood of severe psychological distress, heavy drinking, or heavy smoking is definitely indicated in those data as well. These are pretty recent. That's from the study. It's administered every year, but these are data probably with about a year time lag, so 2015 data that come out in 2016. The Institute of Medicine in 2011 came out with a very major report on the health needs of LGBT people. This was revolutionary because it was one of the first times a government agency in the United States said, these are the health disparities that are out there, and this needs to become a priority in terms of our governmental needs. We need to provide resources to work to eliminate these disparities. The brief summary there is that the elevated rates are found in regard to depression, anxiety disorders, and substance use among LGBT individuals. If you compare in another study that actually did use also population-based sampling methods, just to give you a sense of the rates of these different conditions, if you ask people, have you been depressed over the past year, or have you had a bipolar disorder over the past year? And you ask, of course, much more sophisticated questions than that, but you try to get at the diagnostic criteria for those, you would find about 31% of LGBT individuals would identify having had a mood disorder in the past year, compared to 11% of people who are heterosexual or cisgender, which is basically a term meaning non-transgender. The differences for an anxiety disorder, this would be generalized anxiety disorder, social anxiety disorder, being anxious in front of groups of people, specific phobias or specific fears that people might have, 18% for LGBT individuals versus 7.4% for non-LGBT individuals. And a substance use disorder, this is just a whopping disparity here, 50.7%, this is actually lifetime data, versus 22.9%. But these are very significant health disparities illuminated in different studies. Another study that has been conducted on an annual basis for about the past 7 or 8 years is the National Transgender Discrimination Survey. This surveys people who are transgender identified and actually has a pretty substantial sample size as well, 27,000 people in the most recent sample. In 2014, Ann Haas, who's a suicide researcher, came out with this really alarming report indicating that 41% of transgender identified people had had a suicide attempt at some point in time in their lives. This is in comparison to about 5% or less in the general population. So you've got to wonder, what are the stressors that people are experiencing? What are the difficulties that people face that might make them 8 times more likely to have a suicide attempt? And I'll try to help us understand that as I continue with the talk too. The rates were even higher among people who identified as having another minority status, like people who were multiracial, people who were American Indian or Alaskan Native, people with low socioeconomic status. And this kind of compounding impact of intersecting identities has often been referred to as intersectionality. I don't know if people have heard that term or not. Intersectionality is a new term that's being used to describe the fact that we can't just look at these different identities alone. We have to think about how they interact with one another to produce a unique experience for that person. So the experience of an African-American, inner-city, impoverished, transgender woman is going to be different from the experience of a cisgender, lesbian woman living in Chicago who is of middle socioeconomic status for a variety of different reasons that can't be reduced to any of those different identities alone. They intersect in complex ways. Also from the same survey, this is actually 2015 data reported in 2016. People were asked, have you experienced severe psychological distress in the past month? About 40% there, compared to 5% of the general population. These are really striking statistics for me in terms of healthcare providers and healthcare access. 1/3 of respondents had had a negative experience with a healthcare provider. And this isn't just, I didn't like the provider, this is discrimination, perhaps getting a really transphobic response from the healthcare provider, being invalidated with regard to their identity and so forth. And then about 23% had avoided seeking mental health care due to fear of being mistreated. So we have health disparities that we know exist in the population, and then we also have a reluctance of people to seek treatment. So it's a compounding problem. You know, the thing about healthcare is if you don't access it, it doesn't, or if you can't access it, it doesn't do you any good. So this is certainly the case for people who may be avoiding treatment for a variety of different reasons. So I'm trying to keep commensurate with my time. I'm not always the best timekeeper, but I promise I won't keep you here late. Moving into the next phase of the talk where I really want to discuss how do we explain these health disparities? How do we try to understand the statistics that I've shown you on the previous slides? Well, Elon Meyer, one of the major researchers in this area, came out with a theory called minority stress theory in 2003. It's very intuitive. I'll go through it in a pretty good bit of detail. It basically posited that the idea of living as a sexual minority, living as a lesbian, gay, or bisexual person in our current society has additional compounding stressors that happen to us on a day-to-day basis. And as a result of that, we find ourselves at risk for different health conditions. Hendricks and Testa modified this model in 2012 to apply also to transgender and gender nonconforming individuals. So this is one of the major explanatory variables, which I'll go into detail with in a moment. The next kind of category of explanatory variables I'm calling issues throughout the lifespan. So if you think about what are the different periods of time in which people might experience increased stress, bullying and victimization while in school, and I'm going to present some data on the basis of studies that have been conducted looking at rates of bullying and rates of victimization. Stressors regarding coming out, so of course people talk about the colloquially coming out of the closet, this idea of revealing one's identity to other people. It's not a one-time event. I mean, maybe you have a big party celebrating it or something like that, but coming out is an ongoing process. We're often in situations where people don't necessarily know our sexual orientation or gender identity, and you have to face a choice as to whether or not to come out in that moment. And then I'll talk a little bit about some complexities regarding aging of LGBT people. There's a good bit of research looking at the impact of systematic or institutionalized discrimination on LGBT individuals. The thrust of this research is if you look at different policies that are put in place that are either supportive of LGBT individuals or perhaps pejorative towards LGBT individuals, those are likely to have impacts in terms of the health of LGBT people living under those particular laws or in that situation. And then finally, this is another area that's of real interest to me. How do we educate practitioners to become competent and good providers of services to all people, including LGBT individuals? And there's a lot of data to indicate that people's providers are not necessarily well-versed in terms of how to work with an LGBT individual. And then I'll, if I have time, talk a little bit about the concept of historical trauma, looking at the idea that it's not just traumatic events that happen to you personally, it's the legacy of trauma that you have by part of being a member of a stigmatized minority group that might influence your experience, and I'll talk a little bit about that too. So this is Meyer's minority stress model. Study it well because there'll be a quiz at the end. No, I'm kidding. So this is, again, a pretty simple model saying that the idea is that people who have a minority identity are likely to face additional stressors in their lives. Meyer divides these into two kind of primary minority stress processes. The first, I know it's hard to read, I apologize for that. He calls distal processes, meaning things outside of the person, like discrimination or victimization or perpetration of violence that might happen. He would call distal minority stress processes. Proximal minority stress processes are ones that occur within the person. So these are difficulties regarding expectations of rejection. This thought of, if I were to come out, are people going to support me? Is my family going to reject me? Am I going to have to live somewhere else? Concealment and that anxiety around concealing part of your identity that's central to who you are. And then his concept of internalized homophobia, meaning living in a society that has homophobia as kind of a dominant value or something that pervades our daily experience can be internalized by LGBT individuals as well. So bullying and victimization, as I move in and talk about the different things that happen throughout the lifespan, the GLSEN, the Gay, Lesbian, Straight Education Network, does an annual survey of LGBT youth and asks them about a number of experiences that they may have had. These are also recent data. If you look at these, think about the experience. I want you to not just think about the numbers, but think about what it's like to be a kid who might be questioning your sexuality, getting a sense that your gender identity may be different from the sex that you were assigned at birth, feeling different from your peers, And then what is it like to walk into a classroom? Well, 57.6% of kids who identify as LGBT felt unsafe at school because of their sexual orientation, 43% due to their gender expression. Almost a third of kids missed at least a day of school out of the past month because they felt unsafe at school on the basis of these identities. 70.8% are verbally harassed. 27.0% physically harassed because of their sexual orientation. Almost half had experienced cyberbullying, being bullied online by someone on the basis of their sexual orientation and gender identity. And this is the part that really strikes hard at me as an educator and as a member of our society. Of the youth who reported an incident to schools, 63.5% said that the staff did nothing. So you imagine if you're in an environment where you already feel unsafe on the basis of your sexual orientation or gender identity, you're being harassed, very likely to be verbally harassed, also likely to be physically harassed. And if you let officials know about it, nothing is likely to happen. This puts you in a really untenable place. And when you grow up with that legacy, it sets the stage for mental health disparities to occur. Also regarding bullying and victimization, policies forcing transgender youth to use a restroom that does not match their actual gender identity actually does place these risks at youth for further victimization and discrimination. So I know that people are following a lot of things going on in politics these days. I am not making a political speech. However, I would be remiss if I did not point out the fact that policies have an impact on the lives of people who live underneath those policies. Kids who are growing up and realize that their gender identity is different from what they were assigned at birth, if they're forced to use the wrong restroom, wrong for them, they may avoid going to the restroom at school at all, leading to urinary tract infections, all sorts of problems that are associated with that. They may skip school entirely, and certainly they may be at risk for greater victimization if they were to use that restroom because they're singled out and are very different from other kids in that situation. With regard to the coming out process, which I mentioned again is something that happens in all sorts of new and different situations for people, LGBT individuals face being potentially ostracized by family, friends, coworkers, religious institutions. And if you think of each time that I don't know how you identify personally, but other people kind of might identify you as being LGBT or might identify you as being straight or cisgender in a number of various ways throughout your life. You may not even think about it. You show up somewhere and someone says, "Oh, where's your wife?" or "Where's your husband?" assuming heterosexuality. Well, people who are LGBT, whenever we face these different circumstances, the presumption is perhaps that we're not LGBT. So we have to face the decision, do I want to come out and perhaps be the victim of discrimination? Or do I conceal my identity, not come out in this moment, which research shows has a psychological toll on individuals who do conceal their identities. So if you think of this as an ongoing process, this is something that happens on a regular basis for LGBT individuals. Now, in terms of aging, and there's not a lot of research in this area, but that is, points out some really important points. LGBT individuals, as they get older, may face additional stressors that are not experienced by their heterosexual or cisgender counterparts on the basis of maybe not having support from family members, siblings, or offspring in later life, not necessarily having a supportive community to take care of you as you get older. These health disparities set in place at an early age with bullying, victimization, and other experiences that people face become complicated as people get older. Being depressed or experiencing trauma early on in life may lead to other associated problems, and that may complicate the aging process. And finally, a lot of long-term care settings are really not necessarily LGBT friendly. So people might have to face the additional complication of going back into the closet if they decide to go into a long-term care setting that doesn't have any sort of affirmative stance regarding sexual orientation or gender identity. In terms of systematic and institutionalized oppression, I made the point earlier that a number of different studies Many of these are conducted by a researcher named Mark Hatzenbuehler and his team at Columbia University. They have linked a number of different policies and laws to the outcomes, mental health outcomes of LGBT people living in those circumstances. So for example, they did a very nice study where they looked at schools that implemented anti-bullying policies that said, we not only are opposed to bullying, but please don't bully other kids on the basis of sexual orientation or gender identity. Those schools that had inclusive anti-bullying policies, kids who were LGBT living in those areas were less likely to have suicidal behavior. This is, of course, correlational. You can't say that once you implement those laws, you're going to have this beneficial effect, but it's hard not to notice that this has happened in a series of different studies looking at laws and legislation impacting LGBT individuals. One of the studies that I did a study looking at LGBT veterans along with a research team that I was working with at the time. This was veterans who served under the Don't Ask, Don't Tell military policy before it was repealed. So veterans who served under Don't Ask, Don't Tell, if they were to come out, would be ejected from the military, typically on the basis of sexual orientation or gender identity as a dishonorable discharge. Folks who were serving during that time who experienced a lot of anxiety around concealing their orientation were much more likely to have depression currently, much more likely to have anxiety disorders and substance use problems. So it's this concealment that takes a toll on people. Hatzenbuehler's research also looked at, and this is 2010, so you're probably noticing this is prior to national marriage equality happening in the Obergefell versus Hodges decision. At this time that Hatzenbuehler conducted the study, he was looking at states that had a constitutional amendment on the ballot to limit marriage to a union of one man and one woman. If you were living in Montana during, I think it's 2008, we had one of these on the ballot and it did pass. There were a number of other states, actually 19 states had amendments like this on their ballots. And in the states where that passed, Hatzenbuehler and others found increased rates of depression and anxiety among LGBT people living in those states. So there is an impact of these different laws. There's a psychological impact of living in a place where the majority of people had said, we don't want you to have the same rights as heterosexual people do or cisgender people do. Non-discrimination ordinances for housing and public accommodations. There's a good bit of research looking at the relationship between these and mental health as well. We live in Missoula. Missoula was well, maybe you live in Missoula. You're here in Missoula right now. Missoula was the first city in Montana to enact a non-discrimination ordinance that included sexual orientation, gender identity, and expression in 2010. A number of other Montana cities have followed suit. Butte, Whitefish, Helena, Bozeman also have non-discrimination ordinances. But it's interesting to think about it. So these ordinances protect you with regard to employment non-discrimination. They protect you with regard to housing non-discrimination, not being denied housing on the basis of your sexual orientation or gender identity. And public accommodations, restrooms, facilities that are used by everyone. Non-discrimination ordinances protect people against these. Think about it from the perspective of an LGBT person living in Montana. We don't have statewide non-discrimination protection. Your rights kind of vary as you travel from I-90 to 93 and you go north into the Flathead Valley. Your rights may vary along the way, whether or not you can be denied a job or denied a place to stay for the night if you're trying to check into a hotel. May depend on where you are at that given point in time. Well, as a state, we do have, I hope the color comes out a little bit. So the states that are in gray don't have any sort of non-discrimination employment legislation that applies to people throughout the state. We have, in Montana, prohibited discrimination on the basis of sexual orientation and gender identity for public employees, not for all employees. So it's important to note that. And really at this point in time, we've got kind of coastal cities and a few in the middle, or coastal states and a few in the middle that really have comprehensive non-discrimination policies statewide. So as I mentioned before, your non-discrimination protection in Montana depends on the city or the area in which you live. We recently had Kelly McCarthy propose a bill to our Montana House, House Bill 417, that would have extended non-discrimination protection, which now is on the basis of gender, national origin, religion, and so forth, was going to extend it to gender identity and expression, as well as sexual orientation. That was defeated twice, actually, in the legislature. It was defeated in committee, didn't make it to the House floor, and then it made it to the House floor in a blast bill and was defeated there. So unfortunately, from my perspective, we're currently in a state where we don't have statewide non-discrimination protection on the basis of sexual orientation and gender identity. I mentioned that one of my particular interests is in practitioners' lack of knowledge. How can we train the next generation of practitioners to understand and be sensitive to the issues of LGBT people who come in to see them? I direct our doctoral program in clinical psychology. I also teach a class on LGBT mental health. We're really kind of the exception in terms of having specific courses in this area for the psychologists of tomorrow. Most practitioners have received little or no training with regard to LGBT issues or LGBT affirmative care. Along with a couple of colleagues of mine, I did a study, it's now pretty old, it's a decade old, looking at substance abuse treatment agencies that said that they provide LGBT-specific services. So there's about 10,000 substance abuse treatment facilities in the US. At the time, 911 of them said, we provide specific services for clients on the basis of sexual orientation or gender identity. We were really surprised by that there would be that many that said they had a specialized service. So we did what I now call our secret shopper study, where we called them up and said, hey, I saw that you list yourself as a program that provides specialized services for LGBT individuals. Could you tell me a little bit about what those services are? And the results were really disappointing. Only 5% of agencies could point to a specific service or program that they had for LGBT individuals. Let me make sure I get the exact data right on this. Over 80% said that they basically had no idea what we were talking about, even though they advertised that in their particular materials. And a lot of programs said, we don't really have a specialized service or program, but we don't discriminate. I don't know about you, but I don't feel that non-discrimination is exactly a specialized service or some sort of bonus that you would hope to get if you go into a treatment facility. So this was a really illuminating study in terms of figuring out there's a gulf between what places say they do and what they actually do. One of my graduate students, Hillary Gleason, and an awesome undergrad, Finn Story, are working on a project that is now under review. Basically, the short story of this is if you look at providers' implicit, like their hidden or unconscious biases, and their explicit attitudes towards transgender individuals, that predicts decisions they would make about transgender individuals in treatment. So it's important to be aware of one's own biases because they might influence how we treat the people that we work with. My little watch is telling me I'm not going to be able to talk about all of this, but I do want to talk a bit about historical or vicarious traumatization. Vicarious or historical trauma is really about, as I said earlier, not necessarily having to experience a trauma yourself, but knowing that because you're part of a group, you may be at elevated likelihood of experiencing trauma, or people who are part of that group before you have experienced traumas or negative events. And I'm going to go through really briefly kind of the concept of historical trauma and how it might be applied to LGBT individuals. I think it's a possible explanatory variable. It's usually been used to explain the experiences of African American individuals with regard to the legacy of slavery, Jewish identified individuals with regard to the Holocaust and anti-Semitic sentiments, Native American individuals with regard to the legacy of loss of land and genocide of their people. And I believe it could be potentially extended to LGBT individuals as well. So two main researchers who really kind of put this concept down into the literature, Braveheart and DeBrine, really talked about this sense of historical trauma among American Indian individuals and what they called disenfranchised grief, like the sense of loss that you can't necessarily put your finger on by virtue of a legacy of having things taken away from you. They said that this was related to increased likelihood of alcohol use and that subsequent generations kind of have a sense of pain that their ancestors experienced. I'm briefly going to go through some of the historical trauma experiences that might apply to LGBT individuals. Some of these may be familiar to you, but not all. So it's estimated that there were 5,000 to 15,000 gay men who died in Nazi concentration camps. Reports are that these men experienced particularly harsh treatment, not that you can really rate one harsh treatment versus another, but particularly awful. And this is the origin of the pink triangle. Do people know this? So the pink triangle, which is often a symbol of gay pride and liberation, was actually used to mark gay men during their time in concentration camps. The reclamation of the pink triangle is a way of saying this is a symbol that has been used to oppress and really to kill us, but we are going to take it back as a symbol of pride in who we are. So it's interesting to think about the historical legacy behind these different symbols as well. I bet no one's heard of this. The Upstairs Lounge Massacre, one of the largest kind of mass murders in American history, happened in the French Quarter of Louisiana, New Orleans, in 1973. This was a lounge that was also part of the time also where the Metropolitan Community Church, a LGBT-friendly church, held their meetings. There was an arson fire in which 32 people died. And maybe, I mean, it's so horrible at so many different levels, but if you look at the media reports during that time, there were radio announcers and TV announcers making jokes about the deceased. There were people who refused to claim the bodies of their relatives because they said they didn't want to identify as having known someone who was at an LGBT place of socialization. Of course, I can't talk about historical trauma without talking about HIV/AIDS. It's estimated that almost 1/3 men who have sex with men have died of AIDS since the beginning of this epidemic, which of course is still ongoing. I don't know if people remember this. I do. In the late 80s, when we were first hearing reports of this deadly disease that was striking gay men, it was called gay-related immune deficiency, or GRID. It's the only disease that I can ever think of that was named after the type of people who disproportionately have the health disparity of getting it. But of course, the term changed after a while. Obviously, the legacy of HIV and AIDS gave many people a sense that if you were growing up as a gay man, your lifespan is probably not the same as that of someone who is growing up as a heterosexual man. You may be likely to die early on the basis of a number of different things. I remember, I was a kid at this time, but I remember seeing news reports about GRID and hearing about there was this disease that was striking gay men. I was way too young to really even be thinking about sex or anything like that, but I knew I was different, or I knew I had a sense that I was somehow different from other kids. And seeing these reports, I kind of connected the dots and thought, there may be something that kills me. I have no idea how or why, but this is disproportionately affecting people who might be like me. The LGBT community obviously galvanized in many ways around HIV/AIDS in terms of providing support from one another, but it can't be underestimated the decimating impact that this had on people. I made reference at the beginning, based on that photo, of the Pulse shooting in 2016, the worst mass shooting in US history. 49 people were killed and 53 people were injured. This is a picture of the different victims who died in that particular shooting. If you think about how do these historical trauma events affect people, like how does it become part of your experience? If you identify as LGBT, you can't help but feel connected to the loss that other people have experienced on the basis of their sexual orientation and gender identity. Indeed, I'm sure many people who don't identify as LGBT also feel that sense of shared loss as well. How it manifests itself, how trauma manifests itself from a mental health perspective is post-traumatic stress disorder. PTSD, also a term that probably I would have had to explain 15 years ago, but now everybody gets it. It's comprised of 4 different types of symptoms that all kind of represent a part of the functioning of a person that changes as a result of exposure to a trauma. Intrusion symptoms, nightmares that keep recurring, unwanted thoughts about the trauma, I believe can happen to people whether or not it's a trauma that happened to them, or if it's you're an LGBT person and you're having intrusive thoughts or nightmares about the Pulse massacre from last year. Avoidance symptoms, avoiding places that remind you of the trauma, avoiding thoughts or feelings that are evocative of the trauma. Negative alterations in cognitions and mood. Edna Foa, who's a major PTSD researcher, says when people undergo a trauma, they have a fundamentally altered belief about the world, where they suddenly believe the world is unsafe and I am vulnerable in it. This, I think, really mirrors the experience of what might happen for anyone who's exposed to a major trauma, but I believe could also happen with regard to historical trauma for LGBT people. And then finally, alterations in arousal and reactivity, meaning that you have an exaggerated startle response, you have sleep disturbances, and other problems on the basis of having experienced a particular trauma. I was going to say something there, but just pretend I wasn't going to because I'm running out of time. These health conditions are interrelated. I focused on PTSD, depression, other anxiety disorders, and substance use disorders. I'm also someone who studies mental health conditions in general. The best data indicate that these all reciprocally influence one another. So having PTSD might lead to having depression over time, which may lead to an increased risk for a substance use disorder, and so forth. I also believe that historical trauma and individual trauma might interact with one another. So for example, someone who's LGBT may have been personally bullied or victimized while growing up. They may have been the victim of a hate crime, had someone to attack them on the basis of their actual or perceived sexual orientation or gender identity. But I think they're also compounded by the different historical things that have happened to LGBT people. Living in Missoula, we had a report of a gay couple that was attacked a couple of weeks ago outside of the Rhino Bar downtown. I would imagine that every LGBT person living in Missoula had some sort of negative thought about what is my likelihood of this happening to me? What is the possibility that someone could attack me if it's happening here in Missoula in our small town, which often feels really safe? So I'll spend my last few minutes on how do we eliminate the disparities. Hopefully an uplifting point. I realize this is not the lightest talk of all, and I appreciate you sitting with me through it. We address trauma through reducing bullying, victimization, and assault. This might be working to have policies that reduce these sorts of events. It could be being a bystander who intervenes. When you see someone being bullied or assaulted on the basis of their identity, being willing to step up for the rights of that other person and say, it's not okay to hurt someone on the basis of these different identities. There's a good bit of research indicating the best way that we overcome prejudices is getting to know someone who has that particular identity, and then we might actually like them, and then our prejudices go away. This is true for racism. This is true for all sorts of different identities, and there's a lot of research looking at this into LGBT identities as well. Basically, someone who knows someone else who is LGBT is much less likely to endorse negative attitudes towards someone who is LGBT, and they're much more likely to advocate for the rights of those individuals. Contact with others. We just have to be talking to each other, and not just online, but really talking to each other. Working to eliminate structural or systematic discrimination. So these are working to dismantle the structures that oppress people on the basis of sexual orientation and gender identity, standing up for inclusive laws and standing up for the rights of LGBT people. And then as a psychologist and a mental health provider, of course, I'm thinking about what do our psychologists that we're training and putting into the world do? I want them to be able to provide what's called LGBT affirmative treatment, being able to understand the experiences of LGBT people, being able to understand the things that contribute to health disparities, and working to provide a safe and affirming environment for someone who may have been invalidated in many other environments in the past. I'm greatly thankful for the Alumni Association for putting on this series of talks. I'm really excited, again, to have been part of it. I'd like to just give a shout out to my department. The Department of Psychology has been supportive of me and my career doing LGBT research since I came here in 2003. It was less popular then to do LGBT research, and I'm really proud to be part of a department and a university that values diversity and really wants to work towards eliminating these health disparities that I hope you know a little bit more about now. I'm happy to share slides with you and address any questions that you might have at this point.
Thanks very much, Brian. That was a great lecture. I know these people in different contexts, but it's really fun to listen to you talk about what you're passionate about and learn a lot about it. Thank you. So as usual, we'll have some time for questions, and we may be able to pull Brian out about some of the issues that he had to leave out because of concerns of time. So, okay, one right over there, President Engstrom.
Thanks, Brian. Great talk. When you were talking about the LGBT-specific approaches to substance abuse, and you found most places didn't have something in place, what were you looking for that would signify that they did have something in place?
Terrific question. I didn't know what we would find, actually. What I did know from working in a couple of different agencies by virtue of my training is that some places had specialized groups for LGBT individuals, so they may have a group that is a safe space for LGBT individuals in substance abuse treatment. So I anticipated that as a possibility, and certainly that was what some of those 5% of people who said they did have something had a specialized group. We also counted if someone said, we have a specific counselor who is trained very extensively, or someone who is our LGBT go-to counselor. We counted that as a specific service too, thinking that the experience of an LGBT client coming into treatment there might be different on the basis of being able to work with someone who has specialized training. But those were the two things, like specialized groups or specific training. Thank you.
Excellent. Some more questions? Yes, Lori.
I wonder about your understanding of the ACLU work on this topic. Anthony Romero spoke last spring about many, many issues, but one was his job as national director to inspect prisons. And the Los Angeles prisons, there was a chill over the University Theater when he went through this topic that the prison made the gay prisoners wear pale blue uniforms so they could be harassed and abused. And so it seems to me that the legal world, outside of policy, but just legal rights defense like ACLU might be another path.
Absolutely. Yeah, I mean, this is a really interesting area of work to be involved in. I alluded earlier to there's obviously political implications of the type of work that I do, and you can't not notice that there are health disparities on the basis of policies and practices that happen in different communities. So the ACLU certainly is known as one of the major organizations working in the US today to really try to eliminate health disparities, not just on the basis of sexual orientation and gender identity, but working towards health equity for all people, and really working to address the systems and structures that perpetuate those disparities. You bring up a really interesting point when you talk about the prison system in California, because you can have policies that are implemented at a certain level, and they might say, we want inclusive treatment, or we want to make sure that LGBT prisoners are treated fairly, and actually where the rubber meets the road, that means wearing a specific uniform that marks you as different from other people. So there's something that's quite clearly lost in translation of that policy into practice. So there really needs to be kind of emerging best practices. Like, what do we do in terms of helping to provide LGBT-specific services? Another example that I've heard of is people who are LGBT in prison are much more likely to be sent to solitary confinement on the basis of not something that they've done, but we think that the person might be safe here. And of course, solitary confinement is one of the most problematic prison treatments that's there. So it's not just in terms of uniforms and other things like that. But I think your point of we really have to make sure these policies and practices are implemented in a way that's consistent with the spirit of eliminating these disparities is an important one.
I have a question, Brian.
Linda.
How do you and your fellow researchers have an idea about how to begin to change the education of practitioners? Because that's a huge task. So where do you start to make sure that psychologists and other medical people and so on have a background in this?
Sure. Great question, and again, something that I'm really passionate about. I'll differentiate between practitioners who are out there already and people who are in training. So obviously, as part of a training program here, I'm really invested in making sure that we routinize the training of students to be inclusive of LGBT identities. And it's not just a separate topic like, oh, we've talked about everything else, now let's talk about LGBT identities. That as we talk about other intersecting differences that people might have or other aspects of diversity, that LGBT identities are included in part of that. That LGBT people are represented in terms of training, in terms of understanding the specific issues that LGBT people face. So, working in terms of making sure that people get and gain competence in working with LGBT clients in psychotherapy is part of what I think is really important for people to have while being supervised by a competent supervisor in that area. With regard to existing practitioners, continuing education is one of the main venues for making sure that people get enhanced training in working with LGBT individuals. That does happen. I mean, I've put on CE workshops for psychologists and other mental health providers and done other types of training. They're not required. So people have to get CEs and they can kind of pick and choose what they want. So I think that there's definitely practitioners out there who never received any LGBT-specific training in graduate school and haven't really gotten anything since. And if you think about the history, I mean, I told you, it's a really short history in terms of our increasing understanding of LGBT issues in mental health. In 1973, being homosexual was a disorder in the DSM. So this is within many people's lifespans here. And thinking about, like, there are practitioners who were training during that time with a pathology model of what it meant to be LGBT and perhaps are carrying that through in their work today. So what do we do in terms of helping? I mean, I like to think that maybe people have positive experiences despite their training. So maybe in working with a variety of different people over time, that also exposes these practitioners to the experiences of LGBT individual in a way that may encourage them to get further training, to do further reading, to become more educated about LGBT issues. But yeah.
Thank you.
Yeah, sure.
More questions? Anybody? Yeah, there's the one in the middle.
I'm also a faculty member here, so I have to ask a question about the theoretical model that you had up there. I think it was Meyer, 93 or something. And I think you referred kind of, and I think it was causes of the mental health disparities, and some of them were internal and others were external. I think you had a distal and proximal
Exactly.
or so.
Yep.
I think, if I remember correctly, you talked more about the external causes. What are internal causes?
Great question. So, and again, the caveat of like causes versus things that are influential, like, of course, as scientists, we cannot infer causality unless we do an experiment where we randomly assign people to certain identities, which obviously doesn't happen, and look at their experiences. So this research is correlational. The internal or the proximal processes are concealment of one's identity, which I briefly touched on, but didn't really say that much about it. You think about how central one's identity is to oneself. Many people don't think about their sexual orientation and gender identities simply because they are mainstream or they're something that is reflected in everyday what they see around them. But for people who identify as LGBT, they often spend a lot of time thinking about their sense of difference from other people and concealing that potentially in a way of avoiding perhaps discrimination or those more distal stressors or minority stress processes. So if we look at concealment, that I think is really something that takes a psychological toll on people. The longer you conceal an important aspect of yourself, it's like holding in a secret from someone you care about. It eats away at you and then eventually does have a toll on your well-being. I didn't talk nearly as much about the
I hope there's not a ton of questions that I'm keeping from being asked. But concealment and expectation of rejection, that's also external in my sense, because I'm concealing because I'm expecting a reaction external for me. So I was looking for something really internal,
really, really internal. Okay.
if there is anything.
I think that you point out a really important point, which is we're in a world in which we're constantly interacting with others, and our mental health is influenced by those interactions. Relationships are the core of human existence, and they can bring us incredible joy and incredible pain and everything in between. So there are no internal processes really that are kind of inherent to the individual who identifies as LGBT. They're probably the byproduct of negative experiences or expectations that we have. So to call them internal maybe isn't the best term. I'll punt that to Elon Meyer and say maybe it's, but I think you bring up a really interesting question. Are there certain aspects of being LGBT that might contribute to minority stress? And I think that there are a lot of understudied internal processes of identity development, what it means to become aware of differences between yourself and other people, how that influences you when you're growing up, and how that influences everything from being shy, which there's probably increased rates, a lot of studies indicate increased rates of shyness among LGBT people. It might be something about realizing one is different and not wanting to interact with other people. But those truly internal processes, you're right, I didn't give as much focus on, and they haven't been as studied. Sure.
More questions? Anyone? Well, if not, why don't we give Professor Cochran another round of applause, and I'm sure he'd be glad to chat with you down here.